I'm going to continue the presentations of the new World Health Organization classification of head and neck tumors for our 5th edition, and specifically as it relates to the soft tissue and hematolymphoid lesions. Again, I do receive book royalties, and as a compliance disclosure, I'm a standing member of the editorial World Health Organization board, as well as an expert member for this particular edition. So let's talk about the soft tissue-related tumors specifically, and in this example, there were 44 diagnoses in 2005, 32 in the 2017 edition, and we've remained the same now, although there has certainly been some consolidation, as well as the introduction of some new entities. So specifically, except for site-specific lesions, all of the soft tissue tumors have been aggregated into a single chapter and then divided by various histogenic groups. Most importantly, things like, glomerulonephrocytoma or biphenotypic sinonasal sarcoma, even sialolipoma, when they are very specific to that anatomic site, have been kept within the anatomy rather than being incorporated into the main overarching group. New entities included in this book include the EBV-associated smooth muscle tumor, the phosphaturic mesenchymal tumors, extraskeletal myxoid chondrosarcoma, as well as the glia-altered soft tissue tumors. There have been new names that have been applied to previous entities as well, like epithelioid hemangioma, formerly known as angiolymphoid hyperplasia with eosinophilia. The rhabdomyosarcoma category specifically has been presented as one group in here, with the exception of the specific fusion-related lesion in the bone chapter, but otherwise not separated out into each of the same classifications was seen in the soft tissue book. And then, of course, Ewing sarcoma has been significantly updated, especially as it relates to the Adamantinoma-like Ewing sarcoma, which I will talk about here in a few moments. So the EBV-associated smooth muscle tumor is a lesion that must have EBV infection and usually in the setting of immunocompromise. By far and away, the vast majority of these develop in the larynx, although they can be seen in the oropharynx as well as in the orbit. The vast majority of the patients have some sort of transplantation history, and it is usually a renal transplant, although it can certainly be others as well. But things like HIV infection, malnutrition, or other events that may cause immunodeficiency have also been documented to be associated with the development of the lesion. Histologically, one of the interesting things about this is it's an interlacing fascicles of spindle to smooth muscle cells with ample cytoplasm. However, sometimes an epithelioid compartment of cells with a very open chromatin and a box-shaped oval nucleus can be seen as well, so giving almost a round cell morphology in some areas. Nuclear atypia can be seen, and of course, increased mitotic activity can also be easily documented, and it tends not to be associated with evidence of necrosis unless it is associated with an HIV-infected patient. All of the immunomarkers that you would expect to be seen in a smooth muscle tumor will also be positive here, with smooth muscle actin, cal-desmin, desmin and SMMHC, or smooth muscle myosin heavy chain, can also be seen. By definition, EBER must be positive, usually by an in situ hybridization technique. So here is an example in the larynx, an intact overlying squamous epithelium with this very small blue round cell or epithelioid type appearance to it. Very, very well-developed open vesicular nuclear chromatin. And in fact, you can see that there are several mitotic figures in this high power field as well. They are positive, as I already suggested, with a variety of markers, including desmin shown here, while definitionally showing an EBV positive reaction in the nucleus of the neoplastic cells. So a new entity for this particular book. The phosphaturic mesenchymal tumor has also been incorporated in this edition as a distinctive neoplasm that is associated with tumor-induced osteomalacia, usually through the production of fibroblastic growth factor 23. And there has to be a clinical pathologic correlation in order to reach the diagnosis. So there must be clinical evidence of phosphate wasting and or osteomalacia that generally is removed with a complete removal of the tumor, and sometimes the FGF23 levels can be identified as being elevated in the serum. Many of these lesions develop in the head and neck, and in fact, it is the second most common location for the tumor, with about 50% affecting the paranasal sinuses. There tends to be a very bland ovoid spindle to stellate morphology and a very richly vascularized stroma, but the pathognomonic basophilic or smudgy matrix material kind of gives you a grungy or flocculent calcification within the background stromal component. Sometimes adipocytes can be seen, prominent thick-walled vessels can also be seen, kind of a myoid appearance to them. And it is interesting to note that many of the head and neck lesions tend not to show abundant calcified matrix. So even though it can be seen as this basophilic material, it sometimes needs to be searched for quite diligently. ERG and D240 will be positive, as well as STAT-B2 and the somatostatin receptors. And obviously, as already suggested, the fibroblastic growth factor 23 can be detected in these tumors as well. So here you will notice such a lesion affecting the bone, and in fact is destroying into it and into the associated sinus. The neoplastic cells are quite unremarkable, just spindle cells set in a background matrix material. Here you can see the much more characteristic calcification, as well as this grungy flocculent type material seen within the stromal compartment. Here is a much better area of that granular basophilic material. In fact, it's seen here adjacent to giant cells that can be seen at the advancing edge of these lesions as well. Here is another example with that myoid phenotype with very dense, thick-walled vessels. And of course, you will notice the adipocytes easily identified. The spindle cells tend to be somewhat bland, and they can range in cellularity from being a bit more hypercellular, as shown here, in comparison to some of the more hypocellular areas shown previously. This is a nice example of the CISH technique, identifying the fibroblastic growth factor 23 as a messenger RNA product, and is a very strong presentation. Extraskeletal myxoid chondrosarcoma. Well, as you know, it's got nothing to do with chondrosarcoma, and so it's a bit of a misnomer as a lesion, but still we kept the name just because it is still well inculcated into the literature. But it is an uncertain differentiation showing a multilobular architecture, abundant myxoid matrix, uniform cells often in this cord or clustered or reticular network, and of course associated with an NR4A3 gene rearrangement in the vast majority of cases, either with EWSR1 or TAF15. Most of the sites within the ENT area are the orbit, but of course intracranial and sinonasal tract can also be seen, and I've seen several actually in the oral cavity. So it has a multinodular appearance with fibrovascular septa, hypocellular lobules with abundant pale blue myxoid to chondromyxoid type matrix, although hyaline cartilage is not seen by definition. There's often a very hypovascular presentation to the stroma. The cords or small clusters, reticulated arrangement is quite characteristic for the tumor, with modest amounts of cytoplasm surrounding around irregular nuclei, and of course these delicate cytoplasmic extensions that go out into the stroma. Unfortunately, the immunohistochemistry is quite nonspecific, with a plus or minus either S100 protein, CD117, sometimes even synaptophysin or NSE, and then of course negative for GFAP and muscle markers. So it is a very challenging diagnosis to reach in many instances. So here is an example where you can see it's involving the skeletal muscle and expanding around a bone in this macroscopic representation of the multinodularity that can be seen. Here on low power, I think you can see the fibrous connective tissue septa as they divide it out into these lobules or nodules of tumor, and the myxoid stromal component is very easily identified. Here you can see on slightly higher power that there's a very myxoid appearance to it, with a reticulated appearance and kind of these anastomosing cords of the neoplastic cells. Again, you can tell how this is quite similar to what one sees with several other tumors, such as a myoepithelial type neoplasm, or perhaps others within the head and neck space. The background matrix material gives you this very myxoid overall appearance, kind of suspending the neoplastic cells within it. And so you can tell how some of the differential diagnosis, such as something like a pleomorphic adenoma even, would be incorporated into the differential. The EWSR1 break apart obviously is not telling you what the fusion partner is, but certainly can let you know that it is associated with the EWSR1 gene. The Glee-altered soft tissue tumor category, or GLI1 altered specifically, is a mesenchymal neoplasm, again, of uncertain histogenesis, kind of thought maybe to be of perivascular distribution or parasitic distribution, but it is defined by the GLI1 alteration. So initially, fusions were described in about 2/3 of the patients, but then amplifications have also been described, sometimes with co-amplification of some of the adjacent and neighboring genes. So about 40% of them occur in the head and neck, with the tongue most commonly affected site within that geographic region. Histologically, there's often a protrusion into the adjacent vessels with a wide spectrum of both architectural as well as cytologic features, ranging from nests and sheets to fascicles and pseudorosettes, cords, or even reticular pattern. Small to medium cells, epithelioid to ovoid, or spindled a shape to them with a variable amount of cytoplasm. However, they do tend to be somewhat monotonous one to another. So it's a monomorphic population of cells, often having these small pinpoint nucleoli. Usually mitotic activity can be seen, but it is limited. There's usually a prominent vascularity, and of course the stroma can range from myxoid to hyalinized. Now, unfortunately, again, the immunophenotype for this is quite variable, and you can see that I've put down things like smooth muscle actin, S100, CD10, CD56, and even CD99. So there is some overlap with a variety of other tumors that can occur in this location. However, they are usually negative with SOX10, HMB45, GFAP, CD34, and P63, as well as the neuroendocrine type markers. Interestingly enough, overexpression of CDK4, MDM2, and even STAT6 have been described in this tumor as well. So here you can see an example of the neoplastic cells as they have gone into a vessel, in fact, associated with some fibrin as part of a clot formation here. Isolated mitotic figures. Here you can see a mitotic figure there and another one out over here, so they certainly can be seen, but I think you can tell that there is an overall monotony to the neoplastic proliferation. Here is that rich vascularity that I was describing previously with extravasated erythrocytes and a very monotonous overall population. Sometimes a more nested architecture can be seen with a little bit more even chromatin distribution, and yet this is still very characteristic of the neoplastic proliferation. Another area here, just to highlight the rich vascularity and kind of a nested architectural appearance. So as I already mentioned, you can have amplification of GLI1, or you may have a rearrangement of GLI1 as identified by this particular fish break apart, but just be aware that you may have to do multiple different techniques in order to be able to document what is going on with this tumor. I will say this is also one of the tumors in the soft tissue section that does, of course, require a genetic alteration in order to be able to reach the interpretation correctly. The Adamantinoma-like Ewing sarcoma category, as you know, is part of the primitive small round cell sarcoma that's defined by a variety of different members of the FET or ETS gene families, with the majority of these occurring within the first 4 decades of life. And of course, for the Adamantinoma-like subtype specifically, very frequently identified within the head and neck area, salivary glands, thyroid, and even sinonasal tract. So it has this lobular architectural arrangement, sometimes a little bit of peripheral palisading, myxoid and even hyalinized stroma, and areas of squamous differentiation can certainly be seen in this tumor as well, although it is not a requirement for the diagnosis. As you would expect for a Ewing sarcoma, CD99 in a membranous type reactivity pattern should be seen, with positivity with NKX 2.2 as well. Now, specifically, depending upon which fusion partner is identified, FLY1 or ERG may be identified as an immunohistochemical finding as well. Now, because it's the Adamantinoma-like Ewing sarcoma, CK-pan and either P40 and or P63 will be seen, although the CK-pan and P40 are by far and away the most helpful findings in this tumor. So here you will notice an example, very small blue round cell category, tumor necrosis easily identified, kind of a granular to coarse nuclear chromatin distribution, multiple chromocenters present with a prominent nucleolus and even mitotic figures. Areas of degeneration or apoptotic change can be seen in this tumor as well, making it sometimes a challenge for that small blue round cell tumor category. Sometimes there's a nice fibrous connective tissue stroma that creates a packeted appearance, as you can see in this example. Now, I've put up an immunoprofile here just to highlight that there are a number of lesions that can be seen within the small blue round cell tumor category within the head and neck. And this is just to show you that the Ewing sarcoma is going to have morphologic and immunophenotypic overlap with several of the other tumors that develop in this anatomic site, but specifically the NKX 2.2, CD99, and that co-expression of P40 with those markers is very helpful in reaching this particular interpretation. Here you will see a very strong reaction in all of the neoplastic nuclei with P40, highlighting the epithelial or Adamantinoma-like appearance of the tumor, while P63 can also be seen, along with even CK56, since I've already mentioned there may be overt squamous differentiation in some of these tumors. CD99 must give you a strong membranous type reactivity. Of course, there can be co-expression in the cytoplasm, but it really is a membranous reactivity pattern that is the most sensitive and specific for those within the Ewing sarcoma family. And then NKX 2.2 is a strong nuclear reaction in almost all of the neoplastic cells, as you can see here. And let me just say that the NKX 2.2, in looking at gene expression profiling, is the downstream target of EWSR1 Fly1 fusion, and therefore it is required for oncogenic transformation in order to become this particular tumor. Let's now transition into the hematolymphoid proliferations and neoplasms. You will notice that 35 different entities were incorporated in 2005, 16 in 2017, and now a slight bump up in the 22 edition, specifically to 22 diagnoses. And again, this is quite specific. Instead of for some of the site-specific lesions, all of the hematolymphoid lesions have been aggregated into a single group. So you will notice the new entities. There are only 3 of them: EBV Mucocutaneous Associated Ulcer, IgG4-related disease, large cell B-cell lymphoma with IRF4 rearrangement, Juvenile Xanthogranuloma, and Erdheim Chester. So let's talk about some of these lesions. So first of all, as the EBV-positive mucocutaneous ulcer, this is a very specific finding that is a self-limited lymphoproliferative disorder, but it has these remarkably polymorphous lymphoid infiltrate with Hodgkin-like cells that are seen in the deep portions of the lesion that can be seen usually in immunocompromised patients. So the immunocompromised can be elderly or autoimmune, obviously iatrogenic related things, and HIV and post-transplant setting as well. Usually a well-circumscribed ulcer. The base has this polymorphous infiltrate with a number of different lymphoid cells present within it, including immunoblasts and plasma cells, and then these large Hodgkin-like cells present in the base. Vascular destruction and thrombosis is usually quite prominent, and so you get a fairly large amount of necrosis. And of course, the neoplastic cells are going to show a mixed population of B and T cell markers, while EBER must be documented within it as well. Sometimes even CD30 and rarely CD15 can be co-expressed in this tumor or tumor-like lesion. IgG4. So this is, as you know, a systemic immune-mediated but mass-forming lesion. And it's because of that mass-forming lesion and the association specifically in the submandibular gland and orbit that it has been incorporated in this chapter as well. It is by definition an IgG4-rich lymphocytic infiltrate, storiform fibrosis, obliterative phlebitis, and of course a typically elevated serum IgG4 level can be seen as well. So the combination of those findings, obliterative phlebitis, storiform fibrosis, and the lymphoplasmacytic infiltrate with an increase of IgG4 positive cells is quite specific for the diagnosis, although there are other entities that can overlap it. And even things like an inflammatory myofibroblastic tumor, multicentric Castleman's disease, Rosai-Dorfman, etc., can have IgG4 positive cells. And therefore, this is something that must be thought about and excluded actively. There are also some clinically compatible features. These are related to having IgG4 related diseases in other anatomic sites, having the elevation in the serum of IgG4, and of course, if there's any sort of response to steroid treatment and or rituximab, this should certainly help to confirm the overall diagnosis. So the tables that are present within the book, I've only limited this one to the head and neck areas, but just be aware that especially in the hematolymphoid book, they have the criteria for each anatomic site specifically documented. The old nomenclature or obsolete terminology is highlighted here in the parentheses. So things like Kuttner tumor and chronic sclerosing sialadenitis should no longer be used for the IgG4 related diseases. As you can tell, there are a number of different salient clinical features that need to be seen as well in making this particular interpretation. So I think you can see that there is clearly a chronic inflammatory infiltrate present here, as well as a storiform fibrosis. There is a greatly increased amount of lymphocytes as well as plasma cells, actually destroying the background salivary gland parenchyma in this location. It can also be seen in the sinonasal tract. Here's an example of that lymphoid population and plasma cell population with a storiform fibrosis present just below the sinonasal tract mucosa. Areas of phlebitis, as highlighted by the arrow here, are diagnostic when they are seen, but just be aware that they are often quite difficult to be able to highlight. Here you can see a very rich plasma cell population, which is of course going to be tested for IgG and IgG4. And here you will notice there is a large number of IgG positive cells, but likewise a similar number of IgG4. And so the ratio here is greater than 40%, helping to reach a determination of the diagnosis in this example. The large B-cell lymphoma with IRF4 rearrangement is not something I've ever made a diagnosis of. I will tell you that right now. I am not a hematopathologist, but because it is something that occurs almost exclusively within the Waldeye's ring as its most common presentation, and also in the pediatric age group most usually, we thought it should be included in the book as well. Usually it has either centroblastic morphology, intermediate size with blastoid morphology can also be seen, ranging from either a follicular and diffuse or diffuse growth pattern with positivity with CD20, CD79A, and PAX3, while BCL6, IRF4, and MUM1 are also seen in this lesion. Sort of by definition, IRF4 should be seen by FISH rearrangement as well, with an absence of either BCL2 or MYC gene rearrangements. So here you can see a kind of a diffuse pattern in the lower portion of the field, a little bit more follicular architecture here with a very blastic appearance to the neoplastic cells and very high proliferation index, while here I'm just highlighting two of the immunophenotypic patterns of BCL6 and MUM1, but just be aware that this is a very specific tumor entity category for the new book. Juvenile Xanthogranuloma, clonal infiltrate of non-Langerhans cell histiocytes, showing a favorable outcome for most, except there is some rare association with systemic disease. The skin of the head and neck is most commonly affected, and young patients are the most usual patient-affected group. The histiocytes are intermixed with these fabulous two-ton giant cells that you can see in the upper panel, very characteristic for the lesion, showing positivity with either CD68 or CD163, while they should be negative for Langerhans cell markers such as CD1A or CD207, which is Langerhans. Let's now talk about Erdheim Chester just for a moment to recognize that this is an example of the systemic histiocytic neoplastic condition that involves multiple different organs of mature histiocytes in a background of fibrosis. So when it occurs within the head and neck, it most frequently presents with these xanthelasma-like lesions around the eyes, face, and neck with a slight male predominance, and sometimes will even show areas of sclerosis in facial sinus imaging studies. It is not uncommon to have an underlying clonal hematopoietic lesion or even an overt myeloid neoplasm such as CMML as the most frequently identified. So as you would expect, they're going to be collections of histiocytes, very bland overall cytologic appearance with foamy and eosinophilic cytoplasm. And again, they will be reactive with CD163 and CD68, but negative with Langerhans type markers. So just so you know that even though it is a diagnosis, when you think about the number of times we make a xanthelasma type diagnosis, it is really something that has a remarkably wide distribution across the body. So you can see here are the number of sites and how commonly they are affected, what the various presentations may be, and what are the findings for these entities. So it is something that is a multi-system disease as its presentation. Further, you will notice that there are many different mutations identified in this lesion. While most commonly BRAF mutations with V600E specifically is seen in the majority, there are a number of others that can be seen as well in this multifocal disorder. An example of just the histiocytes, you can tell there's lots of foamy cytoplasm present within it immediately below the respiratory epithelium here with a multitude of histiocytes. And of course, they would be reactive, as I already mentioned, with CD163. That brings me to the end of this particular presentation, and I hope that you have enjoyed our exposure to the new 2022 5th edition of the classification of head and neck tumors. I'll be more than happy to take any questions that you may have at this time and hope you have a fantastic day.